Transformasi teknologi kesehatan. Dari teknologi kesehatan yang berfragmentasi dan tertinggal menjadi terintegrasi dan maju.
Kita telah berhasil memastikan rekam medis elektronik diterapkan dan menggunakan standarisasi serta modul pada ekosistem Satu Sehat Platform. Lebih dari 22.000 pasienkes sudah terintegrasi dengan Satu Sehat Platform yang berstandar global dan memiliki sertifikat keamanan ISO 27001 dan 27799 yang diakui di lebih dari 100 negara.
Diperlukan akselerasi pemanfaatan teknologi biomedis untuk pelayanan kesehatan, termasuk pelayanan kedokteran presisi.
Melalui inovasi bioteknologi kesehatan, mari kita wujudkan kolaborasi ekosistem kesehatan yang inklusif dan peningkatan layanan kesehatan bagi masyarakat Indonesia.
Transformasi internal Kemenkes. Banyak hal yang telah dicapai Kemenkes sejak dijalankannya transformasi kesehatan. Capaian ini didukung melalui transformasi internal Kemenkes yang dilakukan oleh Internal Transformation Office. Sejumlah inisiatif jangka pendek telah dijalankan sejak tahun 2022. Dalam jangka panjang, upaya transformasi internal Kemenkes tidak hanya untuk meningkatkan kualitas dan efisiensi operasional Kemenkes, tetapi juga akan berkontribusi positif pada transformasi sektor kesehatan secara keseluruhan di Indonesia, serta menjadi sumber inspirasi dan pembelajaran bagi organisasi lain. Disahkannya Undang-Undang Kesehatan Nomor 17 Tahun 2023 merupakan awal yang baru untuk membangun kembali sistem kesehatan yang tangguh di seluruh Indonesia. Kemenkes mengajak seluruh elemen pemerintah pusat, pemerintah daerah, swasta maupun organisasi non-pemerintah untuk ikut membangun secara sinergis sampai seluruh penjuru negeri.
Mari kita didik masyarakat kita agar tetap sehat dan jauh dari segala macam penyakit untuk Indonesia emas di masa nanti 2045.
Melesat demi Indonesia Emas 2045. Kemenkes hebat, Indonesia sehat.
Good morning, ladies and gentlemen. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Distinguished speakers, respected colleague, and all participants joining us today, on behalf of the Center for Civil Service Competency Development, Ministry of Health of the Republic of Indonesia, it is my great pleasure to welcome you to the Global Expert Sharing Series 4 with the theme Value-Based Digital Health and Competency Framework. My name is Febry Handiny, and I am Widyaiswara from Balai Pelatihan Kesehatan Mataram. It is my great pleasure and privilege to accompany all of you today as both the Master of Ceremony and Moderator for this Global Expert Sharing Session. Ladies and gentlemen, digital transformation is becoming an increasingly part of health system transformation. However, digital health is not simply about introducing new technologies, but more importantly, it's about how technology can create meaningful value, improving the quality, effectiveness, efficiency, and sustainability of healthcare services, while ultimately contributing to better health outcomes. At the same time, successful digital transformation requires people with the right competencies, knowledge, mindset, and capability to work effectively within an increasingly digital health ecosystem. And therefore, today's Global Expert Sharing provides an excellent opportunity for us to explore both sides of this transformation, the value created through digital health and the competency required to make the transformation successful. And before we begin, ladies and gentlemen, we would like to remind all the participants that this Global Expert Sharing is also part of the learning activities available through the Pelatihan Sehat Learning Management System, LMS. And therefore, we kindly ask all participants to make sure that you are registered and actively following this learning activity through Pelatihan Sehat LMS. Now, please allow me to briefly share today's agenda. And ladies and gentlemen, before we proceed to our main session, I would like to inform our distinguished speakers and all participants that Ibu Dwi Melani S.Kep MKM, Head Center for Civil Service Competency Development, Ministry of Health of the Republic of Indonesia, is unfortunately unable to join us this morning due to an unavoidable prior engagement. But nevertheless, on her behalf, we would like to convey her sincere appreciation and gratitude to our distinguished speakers from Monash University, Australia, for kindly taking time to join us and share their valuable knowledge and expertise in today's global expert sharing session. Once again, thank you very much, Professor Bain and Professor Juliana Sutanto, for being with us today. And with that, we will proceed directly to the presentation and discussion session. And please allow me now to continue my role as moderator and introduce our first distinguished. Once again, welcome to our panel session on value-based digital health and competency framework. Ladies and gentlemen, today's discussion is particularly relevant because digital transformation in healthcare is developing rapidly. Healthcare organizations are increasingly adopting electronic health records, health information systems, artificial intelligence, data analytics, telemedicine, digital platforms, and many other technologies. But an important question remains: how do we ensure that digital transformation actually creates value? And what competency do health professionals, managers, policymakers, and civil servants need in order to work effectively in this new digital health environment? And we are very fortunate to have two distinguished experts from Monash University with us today. Our first speaker is Professor Christopher Bain. Good morning, Professor. Good morning, Professor Christopher.
Good morning, Febry. How are you? Are you hearing me okay?
Yes, your voice is clearly.
Wonderful.
Okay, and it's a great pleasure to have you with us today.
Thank you.
Before we begin, please allow me to explain about Professor Christopher Bain. Professor Christopher Bain is Professor of Digital Health from Faculty of Information Technology from Monash University, Australia. And he has extensive experience in healthcare data, digital transformation, software evaluation, and health technology innovation. Professor Bain will help us explore the important question of how digital technologies can contribute to value creation within healthcare systems. And Professor Christopher, you will have approximately 30 minutes for your presentation, and the time is yours.
Thank you very much, Febry. Terima kasih, everybody, for coming today. I'll let that video quickly play. Wonderful. I'm just going to share my screen. I hope that everybody can see a full screen view of my slides now. Please let me know if not, Febry, but I shall continue talking in the meantime. Again, thank you very much for having me, everybody. It's been a great experience from myself to be working with many of our Indonesian colleagues over the last 12 months in particular, as we had a joint Australia Awards Fellowship grant with Handiny and many other people, and also was great to visit Jakarta several times as part of that and meet Pak Setiaji again and many other senior officials. And I also want to acknowledge my colleague, Professor Juliana Sutanto, who will talk after me, and Juliana's extensive knowledge of Indonesia and the health system and her extensive connections there have enabled us to work together, which is wonderful. I'm going to talk to you today about value-based digital health, just in an introductory sense. There is many things we could continue to talk about beyond this today. Just very briefly, my background was originally in clinical medicine, everywhere from people's homes and primary care clinics to ICU, ED departments over about 12 years. I then retrained as a software engineer, essentially, in IT. I then went back to the health system and I had a series of leadership roles in some large health services, dealing with all sorts of information management and technology issues. Later in that time, I got a PhD in information systems, which is different again to IT, but complementary. And then this November will be the start of my 10th year at Monash after the previous 27 years out in the Victorian and Australian healthcare system. So why should people care about value in digital health? Well, today's audience is heavily government and administrators and funders of healthcare systems, and you are all, no matter where you are in the world, working with increasingly constrained environments. So cost and demand and complexity of care is all going up. Investment struggles to keep pace. So it's important that we deliver value through our digital health investments. For patients and consumers, well, either they're paying for these things themselves or their taxes are paying for them. So patients and consumers should care about these constructs. Clinicians should care because part of delivering value-based digital health is delivering value to clinicians. Plus, they are working under these constraints, and we hope that digital health, and we expect that digital health will improve their ability to work in these constrained environments. If you're working in digital health research and development, well, if your solutions clearly deliver value, they're much more likely to be accepted and used, which should matter to you. And for vendors, it should be self-evident. If you do not provide enough value into the market, then you will not get market success. You may temporarily succeed, but only those products that continue to deliver value relative to the level of investment and cost will remain in the market. That's the way markets work. So we're talking about a new thing here. This is a construct that I put together about 2 to 3 years ago now. And in my talk, I'm setting the scene around this. And then in Juliana's talk, she's going to talk much more about how that's been contextualized into the digital health innovation system in Indonesia. But value-based digital health sits at the intersection of digital health, of health technology assessment, which has been the way that health systems consider technology for many years now. And I mean technology broadly, new drugs, new procedures, new tests. But also information systems has a role here. So information systems is agnostic of domain, so it's not healthcare specific, but it deals with, amongst a number of issues, how do technologies succeed and fail, and why do they succeed and fail, and how do they align with strategy, and what makes them successful or otherwise. And so you can see that all these three pieces of knowledge need to come together if we're due to actually understand digital health and the value it can deliver, or where it fails to deliver value, which is just as important. Putting all this another way, software tools or technologies have features. In a good state, they deliver benefits to individual users or groups of users. But when we have those benefits playing out at scale, that's when we can achieve value. And of course, it's a little more complex than that. And we'll explore the complexity today. So whilst some technologies deliver value for some stakeholders and they rave about them and wouldn't do without them, they may detract from value for other people. And this is particularly important where you have more than one user group, which is often the case in healthcare. So a definition for you, value-based digital health is a discipline area that sits at the intersection of digital health, health technology assessment and information systems, and is focused on defining, delivering and measuring value in all parts of the life cycle of digital health products. And without me going into too much detail today, when I talk about digital health, it's everything from EMRs and scanned medical records and clinic systems, which have a history of nearly 50 years, right up to some very cutting edge digital health tools that might use AI, that are delivered on phones, that use remote sensors and so forth. So that's the scope of what we're talking about with digital health. if you go onto a website called Monash Bridges or Monash University Bridges, you will see we've published probably about 5 pieces of work now that you can easily access around these topics. If you just look up value-based digital health on Bridges, you'll find them, and I'll give you some QR later. So that's all very good, but how do we know we're delivering value from digital health? Now, obviously, there's the broader construct of value-based healthcare, which many people are turning their attention to around the world. And for now, that's not a bad landing place for our targeted attempts at providing value from digital health. We can do worse than this for now. And most people sitting at a high level in healthcare will recognise that all of these 5 things, the quintuple aims of value-based healthcare, are worthwhile objectives. The struggle is, how do we achieve them? The struggle is, what if we improve population health but we cannot reduce cost? What trade-offs are we prepared to make? But these are good ways to think of our landing places for value from digital health solutions. So equity is obvious. How do we improve access to care for everybody? Improving provider satisfaction is a newer one. We know some older digital health technologies like EMRs have not always done a good job of that. They might deliver other kinds of value, but they have actually upset many providers. How do we enhance patient experience, which is increasingly important, and digital health in a cutting edge sense is a great way to do that. When we say reducing cost of care, I actually prefer a slightly broader view, talking about improving resource utilisation, which might increase income, it might reduce cost, it might save bed days. They're all in that quadrant of this circle. And improving population health, people sometimes get a little turned off by this. I prefer to think of it this way. Yes, we're aiming to improve the health of populations, but that starts with improving the health of individuals around particular conditions. So you cannot improve the health of a population of 1 million people if you're not improving the health of individuals. So I view it at both ends of that. So let me talk about the first aspect there, equity of health. I'm going to pull up a couple of examples that apply to each of these landing places, if you like, for value. And I could easily spend hours with multiple examples, but I just want to show you some limited examples in the time we have. So in considering equity of access to care, this is an example of an app for autism screening. The app is called Sense to Know. It was in this study downloaded by hundreds of people and tested across 620 toddlers. The app is a gamified kind of thing where the toddlers can interact with it on an iPad or iPhone. And then the camera in the device would record the child's behaviour in relation to what they're seeing on the screen. And that was used then to actually be analysed by computer vision to pick up cues of autism or probable autism. And it was done with great accuracy. So whilst this is a research study, it's not a small study, it's a large study. It's dealing with an important problem, and that is screening for autism, especially if you don't have widely distributed specialists. So this could easily lower barriers to screening and hence reduce disparities in early access to services. And that might be particularly relevant for somewhere like Indonesia, just as it might be in rural Australia, for instance, where we have less services. A different example of equity through digital health. So you may actually have this kind of a system in some of your hospitals. It is making its way into Australian hospitals. The original article was published in 2019, and it was basically showing how by developing, again, an AI computer vision-based system in conjunction with traditional colonoscopy, you could dramatically improve the adenoma detection rate of colonoscopy by 50%, from 20% to 30%, particularly because by adding the computer vision, you were able to pick up a whole bunch of smaller lesions that the human eye could not pick up. Fast forward to even just 5 years after that, this kind of a system, the EndoAid system, is in use in Australia. This was as of several years ago. So very quickly, this went from a research study to an implemented system in a hospital. And when I speak to clinicians using this kind of technology now, it seems to have settled and found a place. The interesting thing I'm trying to impress upon you here with equity in mind is if you can better pick up, even if it's a slightly oversensitive approach, lesions in a colonoscope, maybe less skilled people can do more colonoscopes. So maybe nurse practitioners, maybe general practitioners, and hence the workforce who can undertake colonoscopy can be bigger, and hence that promotes equity of access. So we look at improving provider satisfaction. There's no data here, but I can tell you now from when I first made this slide that the data does exist. So this is in the space of AI scribes or ambient voice technologies. There's many of these products around the world now. Some of the big EMR vendors are also developing their own products. There's a number of companies out of Australia. So Meadow is one, Heidi is one, Lyrebird is one. And we now have a patchwork of evidence. We know anecdotally that the vast majority of clinicians who use these tools, particularly in an outpatient clinic type setting, they do not want to give them up. They are finding them to be valuable. Sometimes that value is a little bit of time back in the day, or it's less mental stress of having to catch up on documentation. Sometimes it's the freedom to be able to focus on the patient in the consultation and actually engage with them and listen to them rather than listening with one ear whilst they vigorously type on the computer. So various dimensions of provider value are being delivered through these technologies. Provider satisfaction in a different sense. So this was an exploratory study using ChatGPT, so a large language model, as a way to, an alternate way to deliver information sufficient for consent. So could we get to a point where for certainly routine kinds of patients, for routine kinds of cases, could be delivered a consent explanation and hence give their consent formally by using an LLM? And you can see in this exploratory study, and this was in the hypothetical setting of a tonsillectomy, both patients and medical staff found the information clear and they were quite satisfied in 3/4 of cases. So that's quite an interesting thing, especially if you could save the time of busy clinicians. Maybe the busy clinicians only then need to speak through the particularly complex cases individually with patients. So just research, but it points to value in provider experience. We think about enhancing the patient experience. This is now an 8-year-old study nearly. It's using a system called Cardia, which is made by a company called AliveCore. This is a classical digital health intervention, which is a digital therapeutic and a digital diagnostic for cardiac rhythm disturbances. This company got their first FDA clearance in 2014. So this is 13 years ago. And as you can see with the little picture down the right there, this is one version of the product, but it allows people to do patients themselves. They do not need a healthcare provider to instigate a 6-lead ECG recording on their phone. And the study being spoken about here is in the setting of a paediatric emergency department in Scotland for children with palpitations. And this was a study comparing sending the children home with a traditional Holter monitor versus sending the children home with their parents, obviously, with the Cardia device. And what they found was the children and the families who used the Cardia device picked up a diagnosis 4 times more commonly than the traditional Holter device, and they much preferred, in terms of satisfaction, the Cardia device to the Holter device. So this is starting to flesh out some interesting issues. So patients and families preferred it more, diagnostic accuracy was better, Cost, we don't know. Maybe it was cheaper. That's starting to really add up a positive multidimensional value proposition for cardio. But you need to trade all these things off and decide which of these dimensions of value are most important to you in your situation. Different study, again, a research study looking at AI-based screening for diabetic retinopathy. So over 200 adults had retinal imaging during a routine primary care family physician visit. Basically, that was a very successful examination in the vast majority, 94%. And in 22% of cases, the AI detected significant diabetic retinopathy, and then 76% of those patients went to their appointment. So there's interesting questions about population health improvement. But importantly here, a patient satisfaction survey showed a high average score of 4.8 out of 5. So from a patient experience perspective, this was a very positive intervention. And that could be factored in then in terms of, would we roll this out further? Would we pay for it? Reducing the cost of care and reducing resource use as a proxy. This was an interesting study looking at patients having courses of radiotherapy and pertaining to the issue of their follow-up after radiotherapy. So in this case, a machine learning algorithm was used to find those with at least a 10% risk of needing another inpatient episode during their radiotherapy care. So screened population using machine learning. And then those people who were screened as having that higher risk, half were given the traditional kind of care, which was a 2 times a week evaluation. The other half were given 1 time a week evaluation with then additional evaluation as needed, which was the intervention arm. And interestingly, the intervention group, so less planned care, ad hoc care if needed, actually had fewer subsequent acute care visits, so a significant difference, and clearly lower mean adjusted costs. So using this machine learning algorithm and then giving these people a new model of care off the back of it was cost efficient. That's the take-home message then. Different kind of study. This is in the setting of sepsis in ICU, which has been the focus of different kinds of computational interventions for a long time. This is a smaller study. There's about 70 odd patients in the control arm and in the intervention arm. In the control arm, these patients had their usual sepsis detection, which would have been embedded in their EMR and probably quite an old style algorithm. In the intervention group, they also used a newer machine learning algorithm. And in the intervention group, the average length of stay decreased by about 25%, which is enormous in relative terms. It's very hard to wipe 25% off the length of stay in most hospital systems these days from a single intervention. But even more impressively, in-hospital mortality ratio decreased by nearly 60%. And whilst these people did not explicitly measure cost and resources, clearly, if 60% less people are dying and the length of stay is diminished by 25%, you are saving costs and resources. So that's another really clear example of resource implication. And I'd be very sure if you ask the patients and their families, their satisfaction will be higher, almost undoubtedly. Improving population health, or if you like, improving clinical outcomes. This is a product called DNAV from the US. In this particular study, DNAV was used in a population of type 2 diabetics, but whom were insulin dependent. And DNAV is an AI-guided, personalised insulin dosing tool. And so in this study, again, about 90 in each group, the baseline, the control group went about dosing themselves with insulin in whatever way they usually did. In the intervention group, they used the DNAV system. And in the intervention group, they got a 3 times better reduction in HbA1c or medium to long-term glycemic control than the control group. So that's wonderful from a population health perspective and an individual perspective, albeit it's only for about 6 months in the study period. But importantly, no more hypoglycemia, so no more safety risk. So another clear example of improving the health of populations. This example was looking at a managed care type organisation in Israel who were doing screening for hepatitis C carriers. And so they had a traditional approach to testing people. And then in the intervention part of this study, albeit on retrospective data, they used a machine learning algorithm to try and more precisely identify who should be screened compared to their older approach. And effectively, the machine learning-based approach was 100 times more efficient. They had to screen 100 times fewer people to find the same number of hepatitis C carriers. So that would also undoubtedly, if operationalised, have cost efficiency and resource implications, but clearly that's a great way to improve the health of a population. So they're just some examples, limited range of examples in our time frame to show you how you might use that map of the quintuple aim as a way to assess which of those things were improved by different digital health interventions. And already we've discussed how some of those digital health interventions actually tick off a few of those categories. They're not just focused in one category. I want to just briefly compare that for you with the typical sort of health technology assessment study when we're dealing with a new candidate drug, okay? So this is a study, I picked this up last year, about the cost effectiveness of a new drug called cenobamate as a way of treating focal epilepsy in adults with poor seizure control. And as usual, there's lots of data inputs and there's assumptions re costs and benefits. There's assumptions about disease states and transitions. And then they assess the quality of life using a thing called the SF6D. So what they're doing in this study is quite typical. I've chosen it because it's quite a typical HTA type study. And basically they look at the total costs of using this new drug, which is sometimes more expensive, sometimes less expensive, and they factor in drug prescribing costs and saving of admissions and all that kind of stuff. And they also then compare to quality of life changes in the candidate population. And so the finding was in this study, the treatment was associated with a total cost of £151,000 and 7.5 for QALYs. And basically it allowed them to draw the conclusion compared to all other existing drugs that this was a cost-effective way to do it. So cenobamate was dominant over all comparators with the lowest cost and the highest quality of life year gain, quality adjusted life year gain compared to other similar therapies. So that might allow allow the company to go to government, but allow government to maybe say, okay, well, if we're going to spend a certain amount of money on these drugs for epileptic patients, we think this new drug is actually worth it. And we will help fund it, or we might defund other drugs which look less effective now. Okay. The trouble we have and the challenge we have, but also the opportunity we have, is when we bring that thinking back to digital health, it's nowhere near as simple. And if we open our minds to the various ways digital health interventions might impact those 5 quintuple aims, yes, we could do that kind of analysis we've just referred to in some way. But if we wanted to look at provider experience, because sometimes these interventions need the providers to do something different, even if it's really good for the patient, they'll need to change how they practice. So we can measure that with things like the system usability scale or the National Use of Health Information System Survey from Finland. We've done some work with that in Australia. Things like the NASA Task Load Index can all look at the impact of using the technology on the provider. Obviously, we can add things like prems and proms that can be targeted, or you could use existing ones from ICHOM. Australia has a patient experience survey. There's NHS patient surveys, because we're looking at standardized instruments that we can try and compare across digital health interventions, across countries, across the world. We could look at reducing resource use, so efficiency. That could be things like what a healthcare professional says about it. It could be hours spent by healthcare professionals, certainly. It could be things like productivity adjusted life years for the patient, which is a newer health economics metric, somewhat equivalent to QALY, but much more about the ongoing workforce and societal productivity of patients. And then we can look at things like equity of care outside of the clinical outcomes. So did this intervention, think of that autism app I mentioned before, did we show a change in health equity by using this thing across a population or a subpopulation? So these things, just as a QALY could act as various metrics across these 5 dimensions of potential value from digital health, also rooted back to how much money do you need to spend to achieve them. But clearly the complexity potentially goes up quite a lot. So I'm going to wrap up in a second. In terms of what does all this mean? I think this paradigm is very important. The more digital health we do, the more important this paradigm becomes, because we're going to increasingly be forced to make choices about our digital health solutions, and we're going to increasingly need ways to compare them to older therapies, to older drugs, to older kinds of rehab, all sorts of existing, to psychotherapy, using digital things. We need to be able to compare backwards, and that involves then some standardization of measurement. I would argue that we need to move beyond this concept of a minimum viable product, which is often used in product development, and actually talk about a minimum valuable product. So if you're a startup, what value are you trying to deliver? It's a guarantee that if you do not have a viable product, you cannot deliver value, that's for sure. You can, unfortunately, have quite a viable product which goes nowhere near delivering value. That is absolutely possible unless you know in advance or early in the process with increasing certainty, what value are you trying to hit off here? So if you're looking at this from a software development, digital health development perspectives, what value are you trying to deliver across what dimensions for which stakeholders at the end of the day? And as you move down the path, you might refine that view in an iterative approach. But that view allows you to say, well, what's getting in the way of us delivering that value? And to think of it that way from the start. And you might find that despite what you think technologically, when you actually start pinning down your end users, they say, sure, a phone would be lovely, but we don't have phones. So you have to deliver this on a desktop, and that might fundamentally change how you do this. The challenge, of course, is that software quality, which is a construct very separate to healthcare, but should be important to us here, has many dimensions of quality. So usability is one, but so is cybersecurity, so is data storage. So how do you make those trade-offs to deliver value? I guess what I'm saying is, unless you have that sharp focus on what value are we trying to deliver into healthcare at the end of the day, then you cannot make well-informed trade-offs as you go down the path. If we think of this from an assessment point of view, so I'm looking to buy a product, or in government fund a product, or across my massive health system fund a product, what does this kind of thing mean? I think it means that you can ask for and push towards tighter metrics that then provide those value targets for people. So if you're perhaps buying a product, you can say to the market, not just tell us the functionality you deliver and let's check it against what we want, but how usable is that functionality? How have you shown that functionality improves workforce satisfaction in other environments. And so that lets you have a greater level of control and direction over people building products for you or selling you products. We're pushing more and more generally in health technology assessment towards more real-world evidence. We cannot just rely on RCTs and perfect evidence. So that has a role in this. And increasingly, unlike that very simple table I showed you, it's a simple table of ICEs and qualities and so forth. It belies a lot of underlying complexity, but when we're trying to consider the value across multiple dimensions of a digital health solution, we cannot operate with that level of simplicity, or else we can't get a true picture. And so that lends itself to thinking about multi-criteria decision analysis. And so even for one digital health solution that might cover 3 or 4 aspects of value in the quintuple aim, one purchaser might value cost and resources above all else. Another one might say, no, we've been burnt with our EMR. We value usability and provider experience higher. And so in assessing these products, you need the ability to juggle a bit, make your own trade-offs, which is more than a simple table output like the one I've showed you. When it comes to those actually making funding decisions, especially in government, again, that multi-criteria decision analysis approach I think is important. Real-world evidence post-release is important. So monitor, especially when it comes now to things like AI, which we know often isn't static, especially when we're talking about solutions with generative AI. We need to be alert to the fact that those things are not like releasing a new drug into the environment. If you treat the drug and store them properly, they're going to always work in the same way. This is not true of software-based tools. And so some of you may be aware of the DIGA scheme in Germany, which is a government subsidised prescribing scheme for digital therapeutics. Which is fairly unique internationally. They have just released an expectation into the market that those people providing those products, those vendors, will measure on an ongoing basis patient experience, prems and proms, and also patient health status. Now, and that's the sort of thing we're talking about here, amongst others. Interestingly, they can't and don't mandate it because they cannot force patients to do it. But nonetheless, they've stated this expectation upon the vendors. You will get access to these slides later, I believe, but just very quickly, I mentioned Monash bridges before. Please don't stress if you cannot access these QRs right now. I'll just leave them there briefly for a second. You will get those QR codes in the slides later, or if you just Google Monash University bridges and digital health or value-based digital health, you should be able to, find these publications very easily. And that is my email address if anyone's interested in following up. But that's all I had for you today. I hope that's interesting. I hope it makes sense. It's very difficult in half an hour to get across many years of thinking, especially when they're new concepts. But I hope that's helped somewhat in having you understand what we're talking about when we're talking about value-based digital health. Thank you. Terima kasih.
Well, thank you very much for the insightful presentation, Professor Chris. And there are several important points that we can take from your presentation, particularly regarding the idea that digital health should not be viewed simply as the adoption of technology, and instead the focus should be whether technology delivers measurable and meaningful value for patients, healthcare professionals, healthcare organizations, and ultimately the health system as a whole. And this provides an excellent foundation for our next discussion. And another important takeaway is the issue of health equity. As digital health continues to develop, and we also need to ensure that its benefits are accessible to everyone, and that digital transformation does not widen existing gaps in access to healthcare. And in this sense, value in digital health should also include fairness, inclusiveness, and equitable access to better health services and outcomes. Thank you once again, Professor Chris. And before we move on, Professor Chris, we kindly ask you to remain with us in the Zoom meeting, as after Professor Juliana Sutanto's presentation, we will continue with a panel discussion and interactive question and answer session involving both speakers. And we would be very pleased to have you join us again for that discussion. Well, ladies and gentlemen, we will now continue with our second speaker, Professor Juliana Sutanto. Good morning, Professor Juliana.
Halo, good morning.
Good morning, selamat pagi, Profesor.
Pagi.
Pagi. Okay. Professor Juliana Sutanto is a distinguished professor of information systems and associate dean for international engagement at Monash University's Faculty of Information Technology. And her perspective will be particularly valuable in helping us understand how organization and their people need to develop the competencies required to respond effectively to technological and digital transformation. And Professor Juliana, you will also have approximately 30 minutes for your presentation. The time is yours.
Okay, thank you. I saw in the comment people asking for translation. So I am Indonesian. I can speak Bahasa. Do you prefer me to present in English or in Bahasa?
I guess you can mix both Indonesia and English, maybe. Or
Okay,
maybe at some point, important point, you can translate in Indonesia, Prof.
Okay, so I will do a mix Indonesian and Bahasa in my presentation.
Yeah.
Tapi untuk nanti Q&A kayaknya harus bahasa Inggris ya, supaya Chris juga bisa ngerti.
Iya, betul, Prof.
Oke, jadi saya akan share screen. Terima kasih atas kesempatan yang diberikan. Untuk kesempatan kali ini, saya akan berbicara lebih lanjut mengenai value-based digital health innovation dalam bentuk kanvas. Dan juga saya akan menutup dengan digital health competency. Tadi Chris sempat berbicara mengenai fellowship ya, Australia Awards Fellowship. Jadi, kami mendapatkan funding untuk Australia Awards Fellowship, itu sekitar 4 bulan dari November tahun lalu, berakhir di akhir Februari, awal Maret tahun ini. Dan temanya itu mengenai value-based digital health di Indonesia. Jadi fellowship itu dari Indonesia dan ada beberapa juga dari Kementerian Kesehatan, dan ada juga beberapa dokter, beberapa medical researchers dari universitas di bagian timur Indonesia, dan mereka terafiliasi juga dengan rumah sakit di sana. Jadi membawa benar-benar multiple people ya, dengan multiple background untuk berdiskusi, membentuk bersama mengenai value-based digital health ini di Indonesia. Nah, di fellowship ini ada beberapa konsep yang kami berikan ke mereka. Saya tidak akan menyentuh semuanya, hanya beberapa saja yang saya sampaikan ke mereka. Chris juga menyampaikan beberapa konsep ke mereka, dan kemudian kita mendesain bersama-sama kanvas untuk Indonesia. Jadi konsep yang pertama itu human-centered design. Desain itu seperti architecture ya, jadi kita harus spend time with a good design. Kalau desainnya itu salah, nanti buildingnya itu go totally wrong dan harus diganti lagi dari awal. Jadi untuk digital, programming is the easy part. Getting the design right is what is hard. And then design itu harus user-centric. Kalau tidak user-centric, tidak ada yang akan pakai atau tidak akan yang akan continuously pakai digital health solution tersebut. Nah, yang paling penting, a particular digital health solution itu is part of ecosystem. Kalau kita melihat ekosistem primary health, misalnya kita kalau bikin new aplikasi itu adalah part dari satu ekosistem. Jadi kita tidak bisa melihat aplikasi itu secara sendiri, secara terisolasi. Kita harus melihat sekitar yang mungkin sudah ada. Kenapa harus dibikin lagi gitu? Mungkin dimodifikasi yang sudah ada. Atau kalau emang butuh sesuatu yang baru, ya itu harus berinteraksi dengan other systems di ekosistem tersebut. Nah, design thinking itu basically itu untuk matching needs-nya apa. Jadi the human needs di match dengan available technical resources within the practical constraint. Jadi kita biasanya banyak yang ngomong ke saya, kita mau bikin AI system ya. Saya tanya dulu, datanya ada nggak? Data warehouse ada nggak? Nggak ada data warehouse. Ya kita harus mulai dari bikin data warehouse dulu. Jadi kita harus match needs-nya dengan technical resources-nya dan ada practical constraint tidak. Jadi kita harus melihat juga ini konteksnya apakah visible tidak untuk dilakukan ini. Dan Chris juga tadi udah touch on that aspect gitu. Jadi essential mindset-nya itu untuk match human needs itu kita harus observasi, kita harus empati dengan user. Saya pernah webinar, terus saya ditanya oleh satu dokter mengenai di Indonesia namanya Hospital Information Systems ya. Dan dokternya bertanya, bilang, kenapa kok dia merasa dengan adanya Hospital Information Systems, waktunya dia untuk interaksi dengan pasien itu jadi berkurang, jadi lebih ketik-ketik gitu, isi-isi gitu formnya. Ya itu sesuatu yang sebenarnya dari desainnya itu sendiri, sebelum waktu kita mendesain, kita harus observasi interaksi dokter dengan pasien, dan kita harus membentuk empati dengan mereka, potensial user, supaya apa yang kita desain itu bisa membantu mensupport kerja mereka, instead of mereka merasa ini kok seperti kayak mengambil waktu yang harusnya mereka spend dengan pasien gitu. Jadi itu yang step yang paling awal, yaitu empati. Dan ini step awal dari design thinking. Jadi kita empati terus sampai ke prototyping, testing, dan balik lagi ke depan. Jadi ada interaksi di antara boxes ini. Prosesnya design thinking itu sangat iteratif ya. Nah, kemudian ada konsep lagi yang kami sampaikan ke fellows ya waktu mereka ikut fellowship, itu system thinking. Jadi kalau design thinking itu bottoms up approach, yaitu human center lens. Kita harus mengerti needs-nya apa, dan ini user centric solution dengan iteratif proses yang saya bilang tadi, mulai dari empathy, define, ideate, prototype, testing, balik lagi, atau ada recursive proses di situ. Kalau system thinking itu yang saya bilang tadi, ini top down approach, lebih ke holistic. Seperti saya bilang tadi, kita mendesain sesuatu itu part of the ecosystem. Jadi kita harus bisa membaca ekosistemnya itu tersebut. Jika kita melakukan sesuatu new masuk ke ekosistem, impact-nya apa ke yang lain-lain di ekosistem tersebut? Itulah system thinking analysis. Jadi system thinking itu making sense dari kompleks sistem, dari ekosistem yang ada interrelated parts, ada boundary, ada perspektif within the system. Contohnya, misalnya ada contohnya, sistem dari car, dari mobil itu adalah bagian dari ekosistem urban system misalnya. Jadi kita kalau bikin policy mengenai mobil itu ada efeknya juga ke urban systems. Kalau kita bisa melihat ke bawah juga, ada lagi sistem yang lain di dalam mobil itu, yaitu misalnya baterai. Baterai itu sistem yang lain lagi. Jadi sebuah ekosistem itu ada larger system, ada juga yang lebih kecil lagi sistemnya, dan semua itu interrelated. Dan misalnya ini, dan waktu kita melihat sistem thinking itu tuh semua ada efek satu dengan yang lain. Misalnya kita melihat populasi. Populasi itu dipengaruhi oleh angka kelahiran dan angka kematian. Dan itu semua ada loop-nya. Jadi sama, kita melihat suatu digital system, di dalam suatu ekosistem itu ada loop-nya juga. Loop-nya itu ada trigger, ada efek, ada konsekuensi, yang itu penting untuk kita bisa tahu dalam kita menuju ke value-based digital health innovation ini. Nah, sekarang saya masuk ke value-based digital health innovation canvas. Apa sih itu value-based digital health innovation canvas? Ini tuh canvas yang akan anchoring Indonesia Healthcare Innovation Outcomes on values. Tadi Chris sudah berbicara banyak mengenai values, ada quintuple values, itu tuh 5 values dari digital health. Dan bagaimana caranya supaya kita tuh digital health innovation di Indonesia itu bertumbuh terhadap value. Jadi kita bikin canvas untuk membantu meng-guide inovator-inovator di Indonesia untuk berpikir lebih sistematis ke arah pada akhirnya tuh value pada ending-endingnya. Nah, jadi yang tadi saya udah mengatakan kan, kita di fellowship ini memberikan beberapa konsep design thinking, systems thinking, ada juga implementation science, untuk resolve innovation paradox. Ada paradox di sini dalam segi digital health innovation yang pada akhirnya hopefully akan lead to intended value. Nah, Mungkin rekan-rekan sudah tahu kalau di bisnis itu ada bisnis model canvas. Apa sih bedanya value-based digital health innovation canvas dengan bisnis model canvas? Ya jelas berbeda karena bisnis model canvas itu di scope-nya itu lebih ke profitable dan segala. Kalau yang value-based digital health innovation canvas itu multi stakeholder dan baseline-nya itu quintuple value yang Chris present tadi tersebut. Nah ini saya memberikan ini kanvasnya dan itu ada linknya. Kalau nanti kan slide-nya bakal di-share ya masuk ke LMS, jadi mungkin bisa coba masuk ke linknya. Jadi ini kanvas yang di-develop bersama-sama dengan fellowship dari Indonesia untuk yang di Australia Fellowship itu. Dan ini kita bisa lihat di bawah kanvas itu adalah anchor-nya dari value. Ini 5 value yang Chris bilang. Jadi ada health equity, population health, patient experience, provider satisfaction, dan cost reduction. Di atasnya ada governance spine. Nah ini konteksnya, kita berinovasi di Indonesia, apapun itu ada governance spine. Jadi kalau kita melihat digital health innovation, governance spine-nya apa? Regulatory pathway-nya apa? Clinical governance-nya apa? Data governance-nya apa? Technological governance-nya apa? Jadi dua ini di bawah anchor-nya value dan ada spine-nya, yaitu governance, safety, compliance, dan technology framework. Nah, kemudian di dalam kanvas itu, kita mulai dari mana? Banyak yang kayak saya bilang tadi, datang bicara dengan saya langsung berbicara AI. AI itu teknologi. Kita harus mulai digital health innovation itu supaya bertumpu kepada value, kita harus mulai dengan discovery phase dan awal mulanya itu adalah what is the health challenge? What is the health challenge that we want to solve? So understand the challenge first. Sometimes health challenge itu tidak bisa di-solve dengan digital. Sometimes. Jadi kita harus memahami what's the health challenge. Apakah memang ada potensi digital solution di sini? Jadi health challenge-nya apa, health problem-nya apa, dan kemudian nanti primary user-nya siapa, user profile-nya apa, pasienkah, dokterkah, ini buat pasien, buat dokter, atau buat nurse, atau buat, jadi kita harus mengerti primary user-nya, demografiknya seperti apa, digital literasi mereka seperti apa, habit behavior mereka seperti apa. Jadi ini yang tadi di design thinking saya bilang empathy. Kita harus empathy dengan users, kita harus mengobservasi, develop empathy dengan potential users yang mereka menghadapi health challenge yang kita define di awal itu. Kemudian yang nomor 3 di discovery ada stakeholder map. Ini yang masuk ke konsep yang tadi system thinking. Stakeholder map, kita bukan hanya melihat misalnya dokter yang menjadi usernya, tapi ada yang lain-lain di sekitar dokter itu, ada perawatnya, ada farmasinya, ada hospitalnya misalnya, ada dinkesnya, ya kita harus melihat stakeholder map-nya yang bakal ada efek secara langsung ataupun tidak langsung terhadap digital health innovation tersebut, dan mungkin mereka menjadi indirect user mungkin ya dari digital health innovation. Sesudah itu barulah sesudah kita discover health challenge, what's the health challenge, what's the user profile, stakeholder map-nya, barulah kita beralih ke desain. Barulah kita memikirkan teknologinya. Jadi desainnya mulai dari mana? Dari architecture dulu, solution architecture. Solution architecture-nya tuh seperti apa? Dan ini sekali lagi solution architecture ini bukan hanya melihat isolated solution architecture, tapi kalau misalnya ini bakal di-embed ke primary health, mereka architecture-nya sekarang apa di sana? Kita embed-nya seperti apa nanti aplikasi tersebut. Kemudian kita juga harus melihat user experience. Kita harus mendesain ini dengan user-centric. Makanya saya tadi highlight design thinking user-centric. Mengenai core feature-nya, usability-nya, accessibility-nya. Saya sekarang pakai bahasa Indonesia, jadi lebih accessible. Dan apakah nanti harus ada offline design juga. Jadi saya juga di Indonesia tuh, saya banyak, kalau saya ada riset di Indonesia, digital health saya akan memikirkan offline first design. Terutama kalau di populasi komunitas ya, karena mereka butuh offline design selain online aspek. Engagement strateginya seperti apa, dan yang paling penting di kanvasnya ini dikontextualize untuk Indonesia. Jadi di desainnya itu di nomor 6 integrasi dengan satu sehat gimana. Jadi harus dipikirkan dari awal buat nanti ini bakal diintegrasikan dengan satu sehat supaya desainnya itu dari awal sudah pas gitu untuk diintegrasikan, interoperability-nya udah jelas. Nah, Sesudah itu phase 3-nya apa? Deliver. Deliver itu kita harus pikirkan evidence plan. Bagaimana caranya kita mau show evidence bahwa this is a great digital health innovation, bahwa ada evidence ke value tersebut. Dan itu yang Chris tadi go through with a lot of examples about evidence. Tapi kita harus plan gimana cara kita generate that evidence. Kita harus plan apakah kita bikin eksperimen, apakah kita bikin case study atau something. Jadi kita harus jelas evidence plan-nya itu seperti apa. Kemudian yang nomor 8 itu scale up strategy. Kebanyakan di Indonesia itu semuanya prototipe, enggak semuanya, tapi kebanyakan banyak yang muncul prototipe, sudah prototipe dia hilang. Jadi kita harus memikirkan scale up strateginya itu go to market strateginya seperti apa. Saya juga mengakui saya sendiri juga misalnya bikin suatu desain sudah di launch pilot ke pilot sites dan misalnya hasilnya tidak seoptimal yang saya pikirkan, yaitu saya balik lagi ke depan untuk ngelihat apa yang bisa diimprove. Jadi harus ada scale strategi. Kemudian harus ada business model. Ini saya bilang design thinking itu harus match needs, technical feasibility, sama juga practical constraint. Karena namanya digital health itu harus ada tahu gimana cara buat sustain the digital health. Ini karena harus ada infrastrukturnya, investmentnya, dan sebagainya. Jadi ini yang tahap phase ketiga. Nah, bagaimana Kanvas ini bisa membantu Kementerian Kesehatan secara menyeluruh, ataupun hospital, ataupun primary health, apapun konteksnya itu, setiap badan itu pasti ada bisa melihat digital health innovation ini di 5 value tadi, quintuple value. Tidak semua, tadi si Chris juga udah bilang, tidak semua digital health innovation itu harus at the end deliver 5 values. Mungkin dia fokusnya ke health equity, atau dia patient experience dan provider satisfaction 2 atau 3. Seperti itu. Tapi yang penting ini adalah jika Kanvas ini guide digital health innovation di Indonesia atau misalnya di konteks rumah sakit misalnya ya. Rumah sakit itu bisa memetakan digital health innovation yang sekarang ini dan lagi ongoing itu dipetakan ke value yang mana. Jadi bisa ditik-tik value yang mana, bisa dilihat mana yang belum difokus, belum ada fokusnya. Jadi mana yang masih ada gap di sini, dan kita di sini harus bikin apa untuk address the gap. Jadi ini juga salah satu fungsi dari value anchor ini tersebut tuh identify gap di value dari digital health inovasi di suatu konteks. Jadi key value proposition-nya itu adalah ini memberikan structure navigation terhadap digital health innovation supaya mengacu ke values. Dan ini ada governance spine-nya. Jadi ini paling important, ada governance spine yang memberikan constraints dan opportunity juga dari inovasi. Kemudian ini multi stakeholder alignment tool, karena saya bilang tadi stakeholder map itu paling awal. Dan dia anchor-nya di quintuple aim. Tadi juga saya sudah berbicara mengenai itu dan Chris menjelaskan banyak mengenai quintuple aim. Dan ini kanvasnya Indonesia spesifik. Didevelop oleh fellows dari Indonesia. Dan ini evidence part scaffolding. Jadi ada scaffolding terhadap evidence untuk si new digital health innovation. Yang tadi saya sudah sampaikan di pilar yang ketiga. Nah, sekarang beralih ke digital health transformation. Kita berbicara banyak mengenai value-based digital health innovation. Kita kalau berbicara mengenai value sebagai outcome dari digital health transformasi, teknologi itu hanya satu elemen saja. Kita harus berbicara juga mengenai prosesnya. Saya kasih contoh misalnya. Misalnya ada inovasi di electronic medical record, tapi prosesnya tidak align dengan workflow di electronic medical record, jadinya tidak akan bisa masuk ke value. Atau strukturnya tidak align. Jadi itu semua harus ada alignment antara teknologi, proses, dan struktur. Dan tadi juga saya berbicara mengenai digital literacy. People is very important because people is part of the elements of digital health transformation menuju ke value. Kita harus build competency of people competency di digital health. Nah, WHO mereka bikin recent report yang melihat mengenai example of competency domains di digital health, dan saya highlight beberapa di sini. Jadi mereka melihat ada cluster yang pertama riset. Cluster ini include kompetensi mengenai leverage research principles. dan various research platforms dan tools critical to health interventions and technologies, aiding ke evidence-based, evidence-informed development. Yang kedua, klasternya informatics. Ini lebih ke essential skills untuk manage, analyze, apply health information and data. Untuk clinical decisions, untuk improve healthcare delivery, quality and efficiency. Essential set kompetensi yang ketiga, data. Ini berhubungan dengan data analysis, working with data, interpret data. Di dalam konteks enhancing patient outcomes, dalam konteks value yang tadi 5 value tersebut. Ada juga digital health competency mengenai patient care, patient-centric care through digital channels. Itu is a competency. Kompetensinya yang selanjutnya communication. Ini kompetensi untuk effective communication and cooperation through digital means in the healthcare environment. This is another set of kompetensi yang important di digital health. Dan selanjutnya, administration, leadership, management, system technology implementation, administration policy dari digital health infrastructure, digital health investment. Jadi ini mereka menyebutkan lebih dari 6 cluster of digital health competency, tapi saya highlight 6 cluster ini saja di sini. Nah, how do we translate this to the context of Indonesia? Nah, ini juga adalah output dari fellowship yang saya bicarakan tadi. Jadi kami bersama-sama membangun 3 tiers of digital health competency framework. Yang pertama, foundational literacy. Foundational literacy itu digital health essentials. Ini untuk equip health workforce dengan core skills dan core understanding untuk supaya mereka bisa berpartisipasi di digital health innovation. Dan tier yang kedua, ini lebih ke management dan leadership. Kompetensi untuk drive digital change dengan digital health innovation. Jadi ini untuk enable healthcare profesional, manager untuk optimize clinical and administrative process, lead local digital health initiative, dan use data untuk service improvement. Tier yang ketiga itu lebih ke strategic leadership, shaping the future. Jadi kompetensi ini, tier ini itu untuk guide design strategi transformation dari broader health ecosystem dengan application of deep and specialized health informatics knowledge. Jadi ini untuk lebih ke Chief Information Officer, Digital Health Strategies, Senior Policy Makers, etc. Jadi ini yang kami melihat potensi di Indonesia untuk membangun digital health kompetensi ini dari tier 1, tier 2, tier 3. Dan ini adalah contoh-contoh komponen di setiap tier ini, tier 1, 2, dan 3, yang mana yang ada fungsi yang berbeda-beda dengan tujuan yang berbeda-beda di different level dari healthcare professionals. Nah, ini menarik, di 2019 WHO itu bikin Global Digital Health Index. Dan mereka assess the preparedness and adoption of digital health di 22 countries. Dan saya cek salah satunya Indonesia. Tapi mereka tidak mendetailkan sedetail-detailnya. Mereka ada beberapa komponen yang mereka evaluasi. Tapi saya cari Indonesia cuma di highlight mereka bukan cuma Indonesia sih, semua country di highlight at higher level. Tapi mereka menemukan bahwa 20 dari 22 negara provide no training in digital health at the pre-service level, dan 17 dari 22 negara did not provide training to enable the acquisition of digital health competencies at the in-service level. Dan ini indikatornya mereka untuk digital health training kompetensi dari 1 ke 5, dari low to high. Kalau secara garis besar di reportnya ini Indonesia itu di-highlight di level 3. Jadi kalau misalnya di level 3 itu juga kan ada beberapa komponen dari pengukuran Global Digital Health Index. Misalnya level 3 itu juga menyangkut soal kurikulum. Jadi level 3 itu berarti digital health curriculum implementation is underway covering an estimated maksimum 25% dari healthcare professionals. Saya cuma meng-highlight aja laporan report ini, dan itu apa artinya? Mereka encourage, jadi WHO itu encourage bahwa negara-negara itu harus ensure bahwa health workforce-nya itu kompeten untuk use digital tools dan teknologi. So not only to innovate but also use digital tools and technologies for learning or for health service provision. Jadi policy maker itu butuh untuk ensure bahwa they address the gaps in the digital health competency dan mereka harus contextualize digital health competency standar nasionalnya tuh seperti apa digital competency. Jadi tadi saya memberikan garis besar kalau di belakang diskusi fellowship ini kira-kira mungkin bisa seperti ini kalau kementerian tertarik standarnya dari foundation dulu ke management leadership ke strategic leadership. Dan ini ada di misalnya di tier 1 di financial literacy itu apa di dalam situ. Jadi misalnya kompetensinya dalam hal understanding relevant legislasi, professional code of conduct, policy and ethics, data privacy, security, understanding benefit and risk of a digital presence, manage online footprint to maintain professional public trust, employ digital technology. Kemudian ada kompetensi juga buat recognize and use the right technology, confidently use appropriateness of application for undertaking role responsibility and so on and so on. Nah, jadi balik lagi ke digital health transformation, itu sangat penting bahwa digital health innovation itu harus bertumbuh ke value. Itu paling penting. Dan untuk mencapai digital health bukan hanya inovasi tapi juga transformasi, kita butuh memperhatikan 4 elemen: the technology, the process, the structure, dan people. Jadi sangat penting untuk kita Indonesia mulai memikirkan mengenai membangun digital health kompetensi dari people. Thank you.
Baik, terima kasih Prof. Juliana atas pemaparannya, ini cukup menarik ya Prof ya. Jadi kalau saya bisa, ini saya juga bantu untuk sedikit menyimpulkan dalam bahasa Indonesia bahwa sebenarnya digital health ini kita tidak jangan mulai dari teknologi tapi mulai dari kebutuhan manusia gitu ya. Jadi aplikasi atau sistem digital yang dibuat itu untuk menyelesaikan masalah nyata itu para usernya. Jadi bukan cuma sekedar provided teknologi yang ada gitu ya, seperti itu. Kemudian kalau digitalisasi itu harus dilihat sebagai bagian dari sistem kesehatan. Jadi kalau satu sistem diubah itu dampaknya bisa ke tenaga kesehatan, kemudian alur kerja, kemudian ada pasien, data record, dan organisasi. Dan itu seharusnya harus dipikirkan dalam satu kesatuan dan tidak bisa dipikirkan secara parsial. Jadi seperti itu ya, Prof. Kemudian untuk ukuran keberhasilan itu bukan dari banyaknya aplikasi, tapi manfaatnya gitu. Jadi yang penting itu pelayanannya menjadi lebih baik, lebih cepat, lebih efisien, lebih aman, dan lebih merata. Jadi berhubungan dengan equity of health. Kemudian tadi juga Profesor Juliana menyinggung tentang teknologi itu tidak akan berhasil tanpa SDM ya Prof ya, yang mampu menggunakannya. Jadi kompetensi digital itu harus disesuaikan dengan peran dan ada yang cukup memahami dasar dan ada yang perlu mampu mengelola perubahan dan ada juga yang harus mampu membuat kebijakan dan strategi. Jadi intinya adalah digital health bukan soal membuat teknologi yang sebanyak-banyaknya, tapi juga bagaimana teknologi ini benar-benar helping people gitu ya dalam memperbaiki layanan kesehatan dan didukung oleh SDM yang kompeten. Kira-kira seperti itu, Prof. Baik, terima kasih atas penjelasan yang sangat menarik ya untuk kita buka diskusi panel hari ini. Well, ladies and gentlemen, please allow me to conclude Professor Juliana presentation in English. So, as we know that okay, The first one is digital health transformation must begin with people, not technology. And one of the strongest messages from today's presentation is the importance of human-centered design. And technology might be sophisticated, but if it doesn't respond to the real needs, behaviors, and environments of its users, it may not be adapted or used sustainably. And good digital health solutions, therefore, require continuous engagement, observation, and empathy with users. And second, we need to combine design thinking with systems thinking. And design thinking help us understand user needs from the bottom up through an iterative process of empathizing, defining, ideating, and prototyping and testing. And third is innovation should be anchored in values because the value-based digital health innovation canvas provides a framework to ensure that digital health innovation in Indonesia is not driven simply by the introduction of new technology, but by the value and outcomes that we actually want to achieve. And the fourth, technology alone is not enough, and we need digital health competency. And the three-tier competency framework presented today is particularly useful because it recognizes that not everyone requires the same level of competency. And finally, there is still an important competency gap that needs to be addressed. And the presentation reminds us that digital health training remains insufficient in many countries, but at the pre-service and in-service levels. So one of the critical responsibilities for policymakers is to develop and contextualize digital health competency standards that are appropriate to national and organizational needs. So once again, thank you very much, Professor Juliana, for the insightful presentation. Baik, Bapak Ibu, sebelum kita memulai untuk question and answer session, sekali lagi saya ingatkan pada Bapak Ibu, jika ada yang ingin bertanya, silakan boleh kita mulai dengan memencet fitur raise hand. Bapak Ibu bisa bertanya langsung dalam bahasa Indonesia, nanti saya bantu untuk mentranslate dalam bahasa Inggris. Oke. Oke, Pak Nanang Kurnia, maybe you can raise, you can unmute your voice dan mungkin bisa langsung bertanya dalam bahasa Indonesia, Bapak, silakan.
Thank you, Ms. Febry. Thank you for the time. Professor Bain and Professor Juliana, allow me to introduce myself. I am Nanang Kurnia, a lecturer from Poltekkes Jakarta II, and I pursue a philosophy doctoral degree, in public health. And saya masih bingung nih mencari itu apa koprom, barangkali ada rekomendasi terkait dengan data science, Prof. Jadi penelitian saya rencananya Governance Challenge for Predictive Genomic Data in Evolving Digital Health System, which scope a responsible artificial intelligence approach. Jadi rencananya penggunaan data genomik yang prediktif itu kan terkait dengan etika bahan transfer, ya, PAPT. Nah itu Mbak Febry minta tolong di translate. Jadi saya rencananya meneliti itu dengan membuat modeling sistem AI yang etik digunakan untuk baik itu tenaga kesehatan maupun untuk para pengambil kebijakan di Indonesia. Mudah-mudahan itu nantinya bermanfaat ke sana. Karena kita sebenarnya sudah ada aturan-aturannya terkait penggunaan AI, cuman dalam penerapannya masih terkendala, mungkin terkendala ya tadi di awal tadi digital literasinya si masyarakat itu sendiri ataupun justru digital literasinya si nakes ataupun pembuat kebijakan. Nah itu mohon solusinya, mungkin ada riset apa, barangkali saya bisa boleh join gitu. Terima kasih Pak Febry. Thank you Professor.
Okay, thank you. Mr. Nanang Kurnia, so he is. Are you a lecturer, Mr. Nanang? Lecturer, dosen ya Pak ya?
Yes, dosen.
Oh, ya, baik. Mr. Nanang Kurnia is a lecturer from Poltekkes Jakarta, and he plan to have a research about government and challenge for predictive genomic and for digital health system. and but he has a bottleneck about to find the data science. Maybe you can answer, and maybe you can find the solution how to find the data science regarding for predictive genomic data. So that's the question, I think, because his challenges is one of the challenges is that the digital literacy for people in Indonesia, especially.
So February, he's saying that he's planning to do a project about using genomic data to predict disease or predict outcomes,
Yeah.
and not quite sure about how to go about it from a data science perspective. Is that what we're saying?
Yes, Professor.
Yeah, okay. All right. I mean, we have colleagues who work with genomic data, both in our faculty and elsewhere. I'm sure it's very doable. They do quite a lot of work with genomic data and machine learning on genomic data and prediction. You'd have to reach out to us with a bit more detail, and we can potentially link you up with people here. The other thing, aside from the technical aspects, is where is this data sitting, the genomic data? Where will it be housed? How will it be stored? Is it in one place? Is it in many places? And the level of approval for use of the data is something we would worry about in Australia. And also then what you would do with the data when you're finished with it is important. And also in this case, there's a key ethical question that comes up, which I'm sure you're thinking about a lot of these things, is where you establish the ability to predict things for individuals, sometimes individuals don't want to know. So sometimes people don't want to know that they've got a high risk of getting a cancer, for instance. So I'm not saying that's directly relevant to your work, but it's something you need to think about in this space. I hope that helps. But there's plenty of technical people and technology pieces that can help you with this. We would just need to maybe coordinate with some other people at our end to help you. Does that make sense?
Yes, Prof. Thank you.
Cool.
Baik, izin Pak Nanang, kalau saya sedikit bisa menyimpulkan, tadi ada beberapa teknologi yang bisa Bapak gunakan ya, terkait tentang data science-nya. Kemudian mungkin juga dengan aksesibilitas terkait tentang digital literasi. Nah, itu juga mungkin Bapak bisa ada beberapa, mungkin juga ada bantuan beberapa artificial intelligence yang bisa Bapak cari di internet salah satunya, mungkin seperti itu. Mungkin Profesor Juliana bisa menambahkan sedikit, Prof?
Iya, jadi kalau kita balik lagi ke kanvas ya, itu kan jadi ada spine-nya tuh governance spine, dan itu berhubungan dengan ethics, dengan privacy, dengan policy tersebut. Jadi kalau saya sarankan sebaiknya coba lihat governance spine untuk inovasi ini itu apa buat predictive genomics ini. Kemudian diukur juga, nanti bisa diukur padanya value yang mau diukur itu apa. Jadi lebih terstruktur gitu, inovasinya lebih terstruktur. Dan jangan lupa awalnya mulanya itu mengenai health challenge-nya apa sih yang mau diadres dengan predictive genomics ini, dan itu akan mengarah ke user, bahkan mengarah ke literasi dari user, dan juga bakal mengarah ke stakeholder map dengan literasi mereka. Jadi Pak Nana mungkin bisa melihat kanvas itu dan mungkin bisa memakai itu sebagai framework, systematic framework untuk meng-guide pemikiran di arah inovasi digital ini.
Baik, bagaimana Pak Nanang?
Thank you, Prof. Juliana. Sangat jelas sekali. Ya, terima kasih atas kanvasnya. Semakin terarah pemikiran saya. Thank you.
Baik, terima kasih Pak Nana atas pertanyaannya. Sekarang, and now we move to Pak Adi dari LLKM Pangandaran.
Iya,
Silakan langsung Pak,
iya,
pertanyaan.
terima kasih. Saya mau izin pakai bahasa Indonesia nggak apa-apa ya?
Baik Pak.
Iya. Terima kasih atas kesempatannya. Presentasi yang sangat bagus sekali dari Prof. Julian dan Prof. Bain. Ada dua hal yang ingin saya eksplorasi, mohon izin. Mungkin yang pertama sedikit melebar adalah terkait dengan ketika kita main-main di sebuah sistem informasi seperti ini ya, seperti zaman sekarang gitu. Bagaimana dengan kerahasiaan data gitu, kerahasiaan data. Karena ini terkait dengan banyaknya di level kami di program gitu ya, banyaknya sistem yang bangunannya itu adalah spreadsheet begitu ya. Lalu kemudian dan lain sebagainya yang sistemnya itu warehouse-nya itu bukan dari kita tapi dari pihak lain gitu. Apakah ini akan menjadi masalah atau tidak, itu yang pertama. Yang kedua adalah terkait dengan value Prof Juliana. Ketika kami ini sedang membangun satu sistem yang mana sistem ini kami ingin memberikan satu kemudahan bagi kawan-kawan puskesmas untuk bisa melakukan analisis data terhadap data yang mereka kumpulkan di RME, rekam medik elektronik gitu ya. Kalau misalkan kita kenal dengan secondary use data ya, secondary use data. Nah, tetapi memang sistemnya itu acak, tidak value-nya itu tidak terstruktur, harus ada strukturnya, people-nya dan sebagainya, enggak, tapi dia sistemnya acak begitu. Ketika sistem ini sudah acak begini nih, Prof Juliana, lalu kemudian kami ingin merapikan gitu ya, merapikan itu menjadi sebuah value yang tadi core-nya itu ada 4, itu triknya atau caranya seperti apa gitu, sehingga memang nanti itu akan menjadi sebuah memberikan dampak yang cukup bagus untuk dunia kesehatan. Terima kasih, mungkin itu.
Baik, terima kasih Pak Adi. Sebelum kita menjawab pertanyaan untuk Profesor Chris, mungkin kita bisa menjawab dulu pertanyaan untuk yang Profesor Juliana, Prof.
Actually, the two questions, I don't know whether the first question is directed to Chris or to both of us. So maybe I can translate the question to Chris. So he asked about data privacy. The first question is about data privacy, data security, because he say that they use a lot of spreadsheets. And spreadsheets belong to a particular company, organization, which is not their organization. So they may also use other application or systems, vendor develop, they don't own it, but there are sensitive data there. So they ask about what's your view about this situation? And how can that ensure this data privacy and security? The second is, yeah.
Just on that one, Juliana. So this is somebody who's working in a hospital we're talking about?
At this some point that excuse me, at this some point Mr. Adi makes an example that these people work in public hospital or public health center.
Okay, all right. Thank you.
So,
Yeah. So do you want to answer that question first?
Yeah, so I mean, I'll assume it's in a hospital or some decent sized organisation. It's a challenge. So at a macro level, more mature organisations, even in healthcare, will have an approach to the issue of data governance, which covers those kinds of things. And so data governance is the orchestration of people and process and technology so that you can better manage data and leverage it. And it includes things like storage and privacy and security and access and all of those things. At a simple level, if I walked in there and I thought it was too open to people, you could restrict where you store some of those spreadsheets, so only certain folders are accessible from. You could restrict down at a spreadsheet level. You can secure spreadsheets. You can put passwords in front of them. If the spreadsheets do not need to stay as a permanent record, you can have a schedule of deleting them after a certain time. But the trend is to move away from isolated data repositories like spreadsheets and old access databases to have more corporate platforms to access these things from. So you'd also want to say, well, how are we getting away from having critical information in a spreadsheet on somebody's computer? Why haven't we got other better ways to do that? So they're all the things that come to mind. Absolutely, in healthcare, you can get caught out by keeping the wrong data on a spreadsheet. Definitely, it's a risk. Yeah, that's a quick answer.
Oke, baik, berarti Pak Adi ini salah satunya yang bisa kita lakukan ya. Yang pertama, kita bisa merestrict file itu untuk beberapa level. Mungkin yang paling dasar adalah bisa menginputkan password. Jadi ada beberapa pengguna yang bisa mengakses itu dengan menginputkan password yang hanya bisa diakses oleh beberapa pengguna. Kemudian untuk spreadsheet yang sifatnya sangat-sangat secure, nah itu bisa dilakukan pengschedulan untuk dihapus. Maksudnya adalah ada beberapa spreadsheet yang tidak permanen, nah itu bisa dalam beberapa periode itu bisa dihapus. Untuk salah satunya lah untuk bisa mensecure data-data yang sifatnya private seperti itu. Mungkin Profesor Juliana bisa ada tambahan, Profesor?
Iya, dan Chris juga mengatakan bahwa sebenarnya paling ideal memang kalau ada data platform sendiri ya dari corporate-nya itu sendiri. Tadi saya memahami pertanyaannya mengenai kalau ini kan vendor, aplikasi dari vendor. Jadi kalau berhubungan dengan vendor ya balik lagi ke service level agreement ya, SLA-nya sama vendor, apakah protects data security sama privacy itu sendiri. Jadi harus lihat SLA-nya dengan vendor tersebut. Mungkin saya bisa juga menjawab yang pertanyaan kedua ya. Jadi ini kan mengenai secondary use of data ya, dan dibilang itu di level primary care ya, di level puskesmas ya, itu sistemnya tuh acak gitu. Jadi saya nangkepnya sistemnya banyak banget dan nggak ada yang standarisasi yang sama gitu ya. Karena saya juga tahu situasi di Indonesia ya seperti itu. Jadi yang paling penting sebenarnya kita harus berusaha standarisasinya itu di datanya itu sendiri. Jadi ya sudah, mereka pakai sistem A, B, C, D, E ya terserah. Tapi kita harus make sure ada di back end-nya itu ada semacam data yang mereka harus push ke situ dengan standar yang sama. Jadi mereka harus ada transformasi ke standar yang sama, di-push ke satu data repository, dan itu tuh ke data warehouse misalnya, dan itu akan bisa diakses untuk mereka semua menggunakan data tersebut secondary use tadi untuk menganalisa sesuatu atau yang membantu kerja mereka atau efektivitas dari healthcare tersebut sendiri.
Baik, kira-kira sudah menjawab kebutuhan dari pertanyaan Pak Adi. Bagaimana Pak Adi? Sudah terjawab, Bapak?
Terima kasih, sudah jelas sekali.
Baik, terima
Thank
kasih.
you.
Terima kasih. Kita juga punya pertanyaan di chat Zoom. Itu ada dari Ibu Heni. She asked about she asked for both of you. Could you please share some experiences or examples of how digital health has been developed at the community level around Monash University and its surrounding communities? Professor Chris?
I think Juliana's got a very relevant Indonesian example she can probably talk to, really.
Yes, so I have an ongoing project about community-based digital health on stroke in Indonesia. Jadi kalau kita map ke kanvas balik lagi ya, health challenge-nya apa? The health challenge in Indonesia is when somebody got stroke, they're hospitalized and then they are released from the hospital. Then there's a missing link there. If they don't go for a checkup, the doctor will not know. And also there is a risk of they get the second stroke or even the third stroke and so on. And the impact will be worse when they have a subsequent stroke. Nah, masalahnya apa? Masalahnya di Indonesia adalah caregiver itu kan biasanya family members. And family members kita riset kita di community, banyak yang tidak paham mengenai stroke. Termasuk apa yang harus dimakan, apa yang nggak harus dimakan, tuh mereka tidak paham, informasi tidak ada, dan mereka community based. Indonesia itu kan community based. Jadi mereka bakal bertanya ya ke community mereka mengenai hal ini, mereka bakal minta bantuan gitu. Jadi it's very important for empowering the caregivers and the community with information and awareness about stroke. Instead of they try to find information on TikTok or other social media, they don't even know whether it is the truth or not. Because when we ask them, they are not sure. Jadi itu very important ya untuk di Indonesia. Dan kita juga menghubungkan di community-based digital health platform itu tuh stakeholder yang terkait, yang bersedia untuk koneksikan. Jadi kita ada informasi mengenai nearby kliniknya di mana, mereka juga ada semacam discussion forum, dan kita co-design ini community based digital health ini dengan komunitas itu sendiri. Jadi kita juga bertumpu ke empatinya terhadap mereka. Mereka ada kebutuhan, mereka ada constraint. Jadi kita mendesain bersama-sama dengan mereka dengan melihat constraint mereka tersebut. Ini ongoing project sih. Kita mulainya di Manado dan Gorontalo, dan sekarang kita lagi mengembangkan itu di Kupang.
Berarti ini
And
masih pilot project ya, Prof?
sorry,
Yeah.
Febry, sorry.
Yeah, Chris.
Okay, Chris.
I have a couple of Australian examples of digital health success stories I'm happy to briefly talk about if you'd like me to.
Yeah.
Yep.
Yes.
So I'll just type in the chat too. If people would like to see, apart from checking our website and the university website, there's an organisation called And Health that helps foster a lot of startups around digital health in Australia. Two examples I'll talk about, which are not our projects, but they're famous and successful examples of digital health in Australia. One is called Cardahab. I'll put this in the chat as well. This came out of our National Science Centre, I believe, and it's basically digitally supported cardiac rehabilitation program. So this is for people after a myocardial infarction or heart failure, and historically they had to turn up and physically attend for cardiac rehabilitation. And often people find that too much. They can't stick with the program. Cardahab is a digitally supported cardiac rehabilitation program, and it's had a couple of randomized controlled trials, and it's much preferred by people. People tend to stick with it a lot longer. And quite a different one from one of our partner hospitals originally is a product called Smiley Scope. And Smiley Scope is what we call a digital therapeutic. So a way of delivering therapy digitally, as is Cardahab. The therapy is rehabilitation in that case. Smiley Scope is a virtual reality system in a little headset. And you use it, for instance, if you have children who are anxious about having a procedure, or you're about to insert an intravenous needle into the child, or you're changing a burns dressing or cutting off a plaster, that kind of thing. And they get distracted while they're enjoying the game in their headset. And so that's also been very successful. Just a couple of quick examples.
Yeah, so there are a lot of examples of innovation in Australia regarding the digital health. Baik, Bapak
Yeah.
Ibu, ini salah satu
I think very important in Indonesia context, if you want to do a community-based digital health innovation, you also have to think about the offline option.
betul sekali.
Yeah.
Untuk menjawab ini saya menggunakan pakai bahasa Indonesia. Jadi Bapak Ibu ada beberapa contoh praktek nyata yang sudah dilakukan oleh Profesor Chris dalam hal inovasi digital health. Salah satunya ini ada Handheld Cardahab and Smiley Scope. Ini untuk aplikasi, salah satunya untuk Cardiac ini sepertinya untuk yang kardiologis untuk bagian kesehatan jantung, dan S.Kep ini untuk kesehatan anak ini. Nah, ini juga salah satu praktek baik yang bisa kita contoh ya dari salah satu inovasi digital health yang ada di Australia. We have a question. We move to another question from Febrina Viselita. She asked about to measure digital competency, where do we find the instrument for Professor Christopher? To measure the digital competency, where can we find the instrument?
This is for the competency of individuals, you mean?
Yes, for digital competency individual.
Yes. I'm not aware of any instrument. There are certainly quite a number of frameworks, and Juliana's mentioned one before, that you could measure people's progress against, for sure. You'll basically just have to tick off versus certain criteria, is all I would do. Yeah.
Oh, so there are no formal instrument for
There may be, but I'm not aware of any. It's not a space I have to sort of think about too much, because I'm well beyond competent, if that makes sense. I have more, when I'm involved in this space, it's more in education about digital health, which of course contributes to competency, we hope, but not about competency assessment frameworks per se. No. What were you referring to before, Juliana? That's not a checklist though, it's a broader framework, yeah.
Yeah. So I highlight the recent WHO report that they look at across different frameworks, and they cluster them into different cluster of competency, digital health competency, and then but they highlighted that it has to be contextualized within the national level standard.
Yeah.
And then I highlighted the 3 tiers digital health competencies framework that we developed together with the fellows. So for Indonesia context, that could be a framework that can be used to for education, which is of course tied back with the competency level, the domain, etc., etc. So if the Ministry of Health would like to explore this further with us, because we develop this framework together with the fellows, is very also there's Indonesian context there as well, then we are happy to have further conversations with the ministry.
Oke. Baik. Untuk pertanyaan Bu Febrina sudah terjawab ya untuk pengukuran digital kompetensi, dan untuk instrumennya bisa kita akses di mana gitu, seperti itu. I think we already have at the end of our question and answer session, Bapak Ibu yang ingin bertanya lebih lanjut terkait tentang digital innovation, salah satunya itu bisa para speakers kita sudah memberikan kontak email ya. Jadi Bapak Ibu jika ada ingin pertanyaan terkait tentang digital health, itu bisa kontak Bapak Ibu narasumber kita di hari ini. Sebelumnya terima kasih saya ucapkan kepada Prof. Juliana atas dan Professor Chris atas question and answer session. And then finally we already reached for the sharing session. We would like to give to our Professor Christopher for closing statement for today's presentation, Prof.
Thank you very much, Febry. Look, I hope if you take away nothing else from my talk today, it's just that we are working very heavily on this area of value-based digital health. I think it's very important to the future of digital health and healthcare, and I would encourage people to think about their digital health interventions and investments that way going forwards. Terima kasih.
Baik, Terima kasih Profesor Christopher, thank you so much. And Profesor Juliana Sutanto bisa memberikan closing statement.
Yeah, so I also hope that the canvas is helpful for systematically guide digital health innovation, value-based digital health innovation in Indonesia. And like I said before, Chris and I are open for further conversations. If you would like us to help develop this digital health competency through education training, we are open for discussion.
Baik, terima kasih Prof. Juliana. Mudah-mudahan kita bisa bertemu secara langsung, mungkin di lain waktu ya. Kira-kira seperti itu. Baik. Again, thank you very much, Professor Christopher and Professor Juliana. Thank you very much for being part of our Global Expert Sharing Series 4. And it has been a privilege and pleasure to have both of you with us. And ladies and gentlemen, this concludes our panel and discussion session. And I will now continue my role as a Master of Ceremony for closing part of today's event. And distinguished speakers, ladies and gentlemen, we are approaching at the end of Global Expert Sharing Series 4, Value-Based Digital Health and Competency Framework. Today's session has provided us with valuable global perspectives on digital health transformation, and more importantly, has reminded us that digital transformation should always remain connected to its fundamental purpose in creating better value for people and for health systems. And at the same time, achieving that value requires continuous investment in our human resources and their competencies. We therefore hope that knowledge and insights shared today will not end with the session, but will contribute to continuing efforts to develop competent, adaptive, and future-ready health human resources within the Ministry of Health. And before we close, we would also like to remind all participants to complete the required participation and learning activities through the Pelatihan Sehat LMS in accordance with the program arrangement. Thank you for your active participation throughout today's session. Once again, our sincere gratitude goes to Professor Christopher Bain and Professor Juliana Sutanto from Monash University, Australia, for your valuable contribution. And we would also like to thank Ibu Dwi Melani S.Kep MKM, Head of the Center for Civil Service Competency Development, the organizing committee, and of course, all participants who have joined us today. Thank you for your enthusiasm and active participation. With that, Global Expert Sharing Series 4, Value-Based Digital Health and Competency Framework is officially concluded. And we hope today's discussion has been insightful and beneficial for all of us. I'm Febry Handiny, MC and moderator for today. Thank you very much for your kind attention and participation. Have a wonderful day, stay healthy, and we look forward to welcoming you again at our next Global Expert Sharing. Good morning and see you later. Assalamualaikum warahmatullahi wabarakatuh.
Thank you.
At Monash University, we believe AI should be shaped with purpose, creativity, and care. It's not just technology, it's a force for solving humanity's biggest challenges. From health and climate resilience to digital safety and equity. Maverick is Monash's 60